In this lecture, we will discuss the two most common oral lesions with malignant potential, leukoplakia and erythroplakia. We have now substantial evidence that carcinogenesis is a stepwise process. So it's both epidemiological and molecular data showing that the cancer lesions occur over at least 1 up to 4 decades. This has been proven first for the colon cancer and has been later on established also for head and neck cancer. And for more than 6 decades ago, it has been observed that some oral lesions are associated with an increased risk of occurrence of oral cancer. These lesions have been first named premalignant lesions or premalignant conditions, but the term nowadays accepted is oral potentially malignant disorders. I want now to draw the attention to the definition. So these lesions are associated with an increased risk of occurrence of oral cancer. So it doesn't mean that these lesions are exactly those that will develop to a cancer. Most likely some of these lesions are removed, but their presence in the mucosa of a patient signifies that that patient has an increased risk to develop oral cancer. And here I took a staining made by some of my students some years ago. You can see it's an oral mucosa biopsy, and you could see here the epithelium and the connective tissue, and you could see here that some cells are brown. These are cells that contain a mutated p53, and some are just blue, which is the hematoxylin that stains the nuclei of all cells. So as you can see, the mucosa of these patients, which is a heavy smoker, contains patches of mutated cells interrupted by patches of normal mucosa. This is pretty characteristic for oral cancer patients, and this is a phenomenon known as field cancerization. What's happening is that maybe one of these lesions will look white or red in the mouth and will ring a bell to the dentist that will take the biopsy in this area. So these will be excised. However, there are many of these patches in the mucosa of this patient, and some of them, when they would accumulate enough mutations, and you know that for humans, a cell needs between 5 to 7 mutations to develop, to expand clonally, and to develop into an invasive lesion. So one of these lesions might accumulate this number of mutations and might become invasive and might become an oral cancer. This is the list, the currently acknowledged list of oral potentially malignant disorders, and it's a very recent publication in collaboration with WHO that has been through all the evidence for each of these particular lesions to indicate an increased risk for development of oral cancer. In this lecture, we will discuss about leukoplakia and erythroplakia. The definition of leukoplakia has been first set in 1978 and it hasn't been changed too much. It is a clinical term indicating a white patch or a plaque of oral mucosa that cannot be scraped off and cannot be characterized clinically or histopathologically as any other disease. Some of the definitions exclude the part with that it cannot be scraped, some include it. Here are some examples, some clinical examples. Here is a quite homogeneous lesion on the rim of the tongue. Here is a lesion on a soft palate. These two lesions are quite homogeneous, and it has been shown that this type of lesions have a lower risk to develop, or these patients have a low risk to develop oral cancer, while the patients that present with alternate or with a more heterogeneous type of leukoplakia, where you have a combination of white and red lesions, particularly in the floor of the mouth, these patients have a higher risk than those with homogeneous leukoplakia to develop an oral cancer. When a clinical lesion of leukoplakia is sent in for the diagnosis, this is one of the answers that can be written on the histopathological report. It can vary from hyperkeratosis and benign hyperplasia till invasive cancer, and I will take you through several examples. Here is one example. The clinical diagnostic has been leukoplakia or keratosis. The histopathological diagnosis is hyperkeratosis. As you could see here, there is an increased layer of keratin, but the architecture of the epithelium otherwise is quite regular. The cells are quite uniform. So this lesion doesn't present any signs of dysplasia, and it has a minimal risk for the patient to develop cancer. This is another lesion. The clinical diagnosis has been the same. Here we don't see the same layer of keratosis on the epithelial surface. However, we could see that there is a much thicker basal cell layer, so there is a hyperplasia. However, these cells again are regular and the architecture of the tissue is not disturbed. The cells still mature normally from the basal cell layer till the superficial cell layer. Again, this type of lesions do not indicate a very high risk for oral cancer development. Other lesions, however, can present some changes, either architectural changes or cellular changes that are very similar to the changes that we see in cancers, and these lesions contain dysplasia. In Norway, we follow the WHO criteria for classifying the dysplasia, so we use mild, moderate, or severe dysplasia according to how these changes affect the basal cell layer, then it's a mild dysplastic lesion. The lower two-thirds of the epithelium, then we have a moderate dysplasia, or the whole epithelium, and then we have a severe dysplasia or a carcinoma in situ. I will take you through the examples of each of these lesions, but before that I would like to show you here the criteria that we are using to guide us to diagnose dysplasia in a tissue. So we look at both architectural changes that are listed here, and we look also for cytological features, mainly abnormal variations in the nuclear size and shape, or in the cell size of shape, or in the staining. Very important, the increased nucleocytoplasmic ratio and nuclear size, as well as atypical mitotic figures. Here is for comparison a close-up of the lesion I showed you before, in which the epithelium is quite regular. You could see the maturation, and these cells, they look quite alike. On the other hand, on the image to the right, you could see that these nuclei are hyperchromatic. They are somehow increased in size, and there is a certain variation from nuclei to nuclei between cells. This is a case of mild dysplasia because the changes are localized in the lower third of the epithelium. In addition to these cytological changes that I've mentioned, you could also see that actually there are some spaces between the cells, like the tram trails, which could also be an indication of the architectural changes in this epithelium. We don't see the same changes in the hyperplastic epithelium. Here is an example in which these changes affect the two lower thirds of the epithelium. So here again, you see that these cells are not as coherent as in a normal epithelium, and also you could see cytological differences, that these cells have an increased nuclear cytoplasmic ratio, for example, and that the nuclei have different size and different shape between different cells. Furthermore, When we see that these changes affect the whole epithelium, then the diagnostic is severe dysplasia or carcinoma in situ. Here is a case of carcinoma in situ or severe dysplasia with quite severe atypia. Here you could see very bizarre nuclei, huge nuclei, higher in the epithelium, as well as you could see architectural changes with these bulging epithelial ridges. However, under leukoplakia, one can find also invasive lesions. Here it's a lesion. Here you could see the epithelium. There is some hyperkeratosis, so this lesion might look white. This fissure might not be noticed, but you could see that the changes are not confined to the epithelium only. There is invasion in the connective tissue, and when one looks more careful, one could see invasive cancer cells deep into the tissue. The histological diagnosis is oval squamous cell carcinoma in this case. The prognosis of leukoplakia varies, of course, according to what is found histopathologically. So, according to the study, there are some differences from study to study, but between 17 to 25% of the leukoplakia have been found to contain a dysplastic epithelium. This percentage is higher when the lesion involves the floor of the mouth. And again, there is some variation from study to study, but between 4 to 17% of the leukoplakia can indicate an associated risk with oral cancer. Of note, a quite high percentage of leukoplakia lesions can regress if the habits are stopped. Now we have the red counterpart of this lesion, which is erythroplakia. Similar to leukoplakia, the definition is a red patch or a plaque that cannot be rubbed off, or by pressure the red color will not disappear, and it cannot be characterized clinically or histopathologically as any other disease. Here are some examples. Again, this is the rim of the tongue towards the floor of the mouth, and here is the buccal mucosa with this lesion. And as I mentioned previously, quite often we see a combination of red lesions and white lesions. For these two lesions, the clinical diagnosis has been the same, erythroplakia. However, in the first lesion, histologically, we see a very thin epithelium, and although it's pretty difficult to evaluate this epithelium, we don't see obvious architectural or cytological changes indicative of dysplasia. However, in the other biopsy, you could see that the cells have an increased nuclei, a hyperchromatic nuclei. There are quite major architectural changes. There is no maturation from the basal layer to the superficial. Maybe there is one superficial layer, but still these cells, they cover the whole epithelium. So the histopathological diagnosis here is severe dysplasia or even carcinoma in situ. So the presence of dysplasia or carcinoma in situ in the red lesions, in the erythroplakia, is much higher than in the white lesions. And also these lesions indicate a higher risk that the patient will develop an invasive carcinoma. What it is to be done when you have a patient with these lesions? Most of the dentists, of course, try to have removed these lesions, but as I told you, removal of these lesions doesn't guarantee that the patient will not develop an oral cancer because of this field cancerization phenomenon. So if you have moved one part of the lesion, which has been proven to harbor dysplasia, then most of the dentists will go back and try to remove the whole lesion if they didn't manage to remove it the first time, but sometimes the lesions can be pretty large and impossible to remove in totality. However, we know that lesions placed on the floor of the mouth are harboring a higher risk for developing that patient to develop an oral cancer. So that's why they are indicated. There are indications to try to remove those as much as possible of those, as well as the lesions in a patient that has other risk factors like abusive alcohol use or tobacco use. If they are candida infected, and many of these lesions are, so usually we do also PAS staining on the slides, particularly if we see a rough surface and maybe some immune cells going into the epithelium. And very importantly, it's an active follow-up. These patients have to be followed up once at each 6 months. And importantly is also to inform the patient about the risk factors, to give counseling for ceasing the tobacco and alcohol habits, and also for the patient to be more aware of his changes in the oral mucosa, to look regularly in the mirror, and if he or she notices changes, to come immediately to the dentist. That's very important, because this is what could happen. For example, that a quite homogeneous lesion quite develop over time into a speckled leukoplakia or a mix of red and white lesions, and these lesions, particularly those that change their color during the follow-up, or if the patient notices the changes, those are the areas that are prone to malignant transformation. That's why if you have a patient like this coming to your dental office, it is indicative to take a biopsy, particularly from the areas that have changed the appearance. So documenting with pictures in these patients is very important, and now it's easier than any other time to take a picture with a phone or with other devices. Just be attentive on how to store them so they are not uploaded to Google automatically. To summarize the discussion so far, oral premalignant lesions are recognized and defined clinically. The preferred term for the histopathological changes that indicate a risk of malignant transformation is epithelial dysplasia, which simply means abnormal growth. And epithelial dysplasia describes the histological changes, so it's not a clinical morphological term. So when you see a white or a red lesion, don't call it dysplasia. It's either a leukoplakia or an erythroplakia. The pathological report will say if it harbors dysplastic changes or not, and how serious these are. Here, this is my take-home message, and that's why I'm also dressed in red, and I took here a picture of the pink, because pink is normal in oral mucosa. Yes, the oral mucosa looks pink because the epithelium is white, is non-vascularized, and is on top of the connective tissue that contains blood vessels with erythrocytes, which are red. So pink is normal. However, when you see red, like I am dressed today, or sorry, white, if you see white, something is not okay. White means that the epithelium is thickened. Might be a simple benign hyperplasia or just a hyperkeratosis, but it's worth checking it histopathologically. Most importantly, please remember, if you see a red lesion that you can't diagnose as any other entity, it's important to take a biopsy, because these lesions might harbor dysplasia, and they might indicate an increased risk for a later development of an oral cancer. So please have a bell ringing when you see a white or a red lesion, because if you don't catch these patients early, these are, for example, some early lesions of oral squamous cell carcinoma. Here is the histopathology of such a lesion, where you see islands of invasive epithelial cells into the connective tissue and into the muscle, and see the keratin pearls here. This is just an artifact of how we process the tissues in our lab. It's important to catch these lesions early, otherwise they will progress to very serious and mutilating lesions of oral cancer that are very difficult and expensive to treat. I would like to acknowledge the contribution to this lecture of Professor Anne Christina Johannessen and the support from the Norwegian Agency for International Cooperation and Quality Enhancement in Higher Education, the NORPART and the EURESIA programs. And if you have any questions, contact me by email. Thank you.